I have only ever worked for an academic medical center in my surgical career. That means that when I finished medical school, I did my residency at Mount Sinai Hospital, which was an academic center. I left Mount Sinai when I was done with my residency and fellowship and went to the University of Pittsburgh Medical Center, which was associated with a medical school. And I stayed there for almost 20 years until I came to the University of South Florida, where I am now. That is not the only career that you can pursue if you get a medical degree, obviously. And actually, in next week's episode, I will be sharing the experience of one of my really good friends from medical school who went in a different trajectory. Regardless, I have always worked in an academic medical center and I have found it to be very rewarding. But I didn't really understand some of the mechanics and financial issues that some of these centers experience. And it's important to know that. It's important to know that because it's going to have an effect on the people who work there and certainly going to have an effect on the patients that we take care of every day. So I'm going to use this first episode to explain a little bit about what I've learned about how these systems work. They're very complex. I think it's sometimes easy to go the route of saying, I wish I got paid more, or I wish these centers cared more about education or research, etc., and not really grasp just how complex a system these are. That doesn't mean that there isn't room for voicing an opinion and having leadership respond to those opinions. There's absolutely room for that. And in fact, I think it should be encouraged. However, what I have learned is that academic medical centers are under a lot of different types of pressures that then get translated to us. And so I think understanding a little bit about the mechanics of that might make it a little bit easier to understand what role we as physicians, as teachers, as researchers play in these systems and understand that why that we are feeling what we're feeling. So that's today. And then in the upcoming sessions, I introduce you to a really good friend of mine from medical school who really did some remarkable things after she was done with residency that is so completely different from what I have done. And I find it really inspiring, and I think you will too. So let's get started. Thank you.
And now a quick tutorial on academic medical centers because knowledge is power. In an academic medical center, there's a teaching hospital, a medical school associated with a university sometimes, and a place where clinical care, research, and education can happen together. We call this the tripartite mission. That mission is to care for patients, teach future generations how to do the same, and engage in impactful research to help the human condition. This feels like an important job, and it is. Because we are doing so many things, a day in the life can look pretty busy. We get up really early, usually before the sunrise, take care of things that we need to at home, and then usually attend a teaching conference of some sort for residents and students, nurses and APPs. We round on patients and get to the OR at least by 8. We teach in the afternoons. We join video conferences nationally and internationally. We do some sports maybe with our families and spend some family time, try to eat and get some sleep, usually with a pager or a phone. While AMCs only make up 6% of hospitals, their impact is very significant. They provide huge economic impact. And when compared to for-profit hospitals or not-for-profit, non-teaching hospitals, they provide the majority of birthing rooms, psychiatric services, transplant services, substance use disorder services, level 1 trauma care, and burn center care. And these have important consequences for the communities in which these academic medical centers reside. A JAMA article from 2023 measured the impact of AMCs to surrounding communities and found an increase in healthy days at home for Medicare patients regardless of where they received their care. At least in this report, the health impact of these centers to the region was measurable. The data I presented comparing the different types of services offered by for-profit hospitals, not-for-profit non-teaching hospitals, and not-for-profit teaching hospitals is available on the AAMC website and is sourced from the American Hospital Association Annual Survey Database for fiscal year 2022. In addition to the clinical impacts, academic medical centers and the research institutions associated with them and with their sponsoring universities have provided a number of important discoveries for our society, including things like Gatorade, gene editing techniques, and they have graduated thousands of residents and students. That said, no money, no mission. The clinical engine is the key driver of the academic medical enterprise. Significant funds flow from the health system to the medical school, and those might be under threat. This report from McKinsey & Company show how margins have decreased from 2017 to 2022 from 4 to 1.5%. Cuts to research and education are not off the table for CEOs, the report said. Most are looking at how to reduce length of stay and increase patient engagement and physician productivity. However, a strong mission drives the clinical engine, and academic medical centers use academic branding all the time. They leverage the research expertise to help get more patients in the door, and that's a good thing. Thus, despite the threats, the sum is greater than the individual parts.
A couple of things are worth noting about the presentation that I just gave. First, the medical school also pays the faculty who are doing the clinical work. So, for example, if you are an internal medicine doctor and you have students rotating on your service, the school will pay for that faculty member to teach their medical students. So, even though it seems like the clinical part of these academic medical centers are providing the majority of the dollars, the funds do flow back and forth. And sometimes I think it's very inextricably connected. I do think it's really hard to put a dollar amount to what the faculty members do to teach the medical students, and then how exactly the clinical dollars go into the school to fund the school. That is really hard to do. And I think when systems try to do that, it can get complicated and it can sometimes get a little bit ugly. There's been consortia to try to tackle these issues and try to get a little bit of a better understanding of how we should look at these things holistically. And that there's, you can look it up there, it's been published. USF TGH was actually part of one of those consortia where I work now. And really the result or the conclusion was the best way to look at this as a whole, is as an entire entity, and not break it down into you do this and you do this and I should get paid more because I do this and you should give me more because I do this. It doesn't work that way. You really have to look at it as something that is very fluid. It goes back and forth, so that if you want to be part of these academic medical centers and you want to be part of the system, you can be. You're going to get some dollars from here, you're going to get some dollars from there, and overall, you're going to contribute to the overall mission that is providing so much to the community. That being said, doesn't mean, like I mentioned before, that we can't ask questions about where some of this funding is coming from. What I think is really striking is that the data that I showed and shared about the margins going down for these academic medical centers over the last couple of years have seemed to correlate with a pretty significant rise in dollars going to the CEOs of the organizations. I don't want this to be like a CEO bashing session. That is not the point. But I think it is worth looking at, how does that happen? Like, how does the decrease in margins for the centers go down as CEOs continue to make pretty astronomical salaries At least in some places, not every place. And I do absolutely understand that they are part of this mission and they're contributing vision. But I do think that maybe a little bit of effort to try to understand how those salaries work might be useful and might be something I bring up in a session later on. The other thing I wanted to bring up was this idea of being an academic. I might have said it earlier, and I think it's worth repeating. The lines between what is academic and what is private practice is not always so clear. I trained and at Mount Sinai. I went to medical school at Mount Sinai. I learned 50% of what I know about medicine from people who were in private practice. I learned how to do a great distal bypass and how to do carotid surgery, and I learned about how to talk to patients from people in private practice. And they were just as much a part of my faculty as the people who were hired by the institution. So there's that aspect. I also knew plenty of private practice people who did really great research, and that exists even now. So just because you are part of a academic institution, it doesn't mean that you are necessarily doing more research and teaching than someone who is in private practice who is associated with a medical center that has an academic name to it. So just think about that. That also, if you go into private practice, you can play a huge role in education. There's plenty of people you are teaching every day. I think that is important to highlight. The final thing that I will say is that this job is a hard one. It really is, but it's really rewarding. It's hard because, especially when you do something like vascular, like people are extraordinarily sick, and you start to look at illness in a bigger context. Like, why is there so much sugar in all the food that we eat? Do we need it? Do we really need sugar in basic packaged food that is supposed to be healthy for you? And when I see that, when I see my patients, I look at the system, oh, like in a large scale. I look at like, how are they getting their cigarettes? What are they being coached on how to eat? They may see something that says lots of fiber and they've been told that is something that they need to eat to be healthy, but actually it's really full of sugar and salt. And it's contributing to their chronic disease, such as diabetes. And then they get uncontrolled diabetes, and then they show up in my office and need like a toe amputation or, God forbid, a leg amputation. So I do think that one of the tasks that we can try to think about holistically is how do we get our society to look at nutrition as food? And that is also going to be a topic that I bring up later on. So I hope people have learned something from this session. I also hope that there is a little bit of food for thought for future episodes. I will be trying to interview an eclectic group of people who I think have just different perspectives that they can add to what we already know and what we already witness every day. And if you have ideas, please drop a line and let me know. I'd love to either be able to respond or to bring on an intriguing participant to interview for this session. So thanks for your attention.